Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
Hi, Jack. How have you been?
I'm doing all right, but I'm worried about my health.
Okay. What's worrying you specifically?
A good friend of mine just died from a second heart attack. We used to play sport together. I can't stop thinking I might be next.
I'm really sorry for your loss.
Thank you.
And I appreciate this is alarming for you.
Yeah, I can't believe it, so I'm glad I had this appointment today to talk to you. I really don't want another heart attack. I'm taking all my meds like we talked about last time, and I feel okay, but so did my friend. We just watched the game together last week.
You're doing the right thing by talking to me about it. Most people in your position would worry and want to make sure they're doing all they can to prevent another heart attack. Would it be all right if we talk about your weight today?
Yes, so glad you asked me about it. My wife is really on me to lose weight, but I can't seem to, especially since I hurt my knee a few years ago. I used to love playing sport. I really miss it.
That must be hard for you. We need to think about ways you can get back to doing something active, and it will really help your health as well. Has anyone ever talked to you about excess weight and the health risks?
I mean, I know that being overweight can cause high blood pressure and clogged arteries, right?
Excess weight can increase your blood pressure and cholesterol. It can also contribute to some of your other health problems like the sleep apnea, and you have prediabetes. And it certainly won't help your knee. The sleep apnea and prediabetes increase your cardiovascular risk, which puts you at a higher risk for another heart attack. And excess weight itself can also increase cardiovascular risk.
That makes sense. It doesn't look good for me, does it?
But the good thing is, when we reduce weight, weight-related conditions often improve, and cardiovascular risk goes down.
Okay.
Is it okay if we go over your weight and your cardiovascular risk today?
Yeah, sure.
So your body mass index, or your BMI for short, is high. It's 35.6, which puts you in the obese category.
Obese, wow.
BMI is often used to assess weight, but it can be inaccurate for some people, especially people with more muscle mass. So we also check your waist circumference, which is a better assessment of belly fat. As we get a bit older, we tend to put on some weight around our belly. And in fact, it's belly fat that is the biggest driver of cardiovascular risk. In other words, the more fat you have around your middle, the higher your risk is for another heart attack. Does that make sense?
Yes, and I'm assuming I fit the bill because my belly is definitely where I put most of my weight.
Your waist circumference is 103 centimeters. Measurements above 102 centimeters increase your cardiovascular risk. So I would like to work with you to reduce your belly fat. We want you to be fit and strong, and it's important that we're doing the right things to reduce your waist circumference.
All right.
Hello everyone, I'd like to welcome you all to this program titled The Patient with High Cardiovascular Risk and Obesity in Cardiology Care, Evidence-Based Strategies for Weight Loss and Cardiovascular Risk Reduction. I'm Dr. Kim Conley. I'm the Division Head of Cardiology at St. Michael's Hospital here in Toronto, Canada, and the Executive Director of the Keenan Research Centre for Biomedical Science. Jack has presented for routine follow-up after his non-ST elevation myocardial infarction 2 years ago. He has dyslipidemia, hypertension, and sleep apnea. And today we're going to focus on why it's so important to address excessive weight in a patient such as Jack. So we know that obesity is a very common condition and it is associated with multiple complications. And of course, we know that the increase in the body mass index is associated with a significant increase in cardiovascular risk. And we see this really goes up even at what I would say the earlier levels of weight gain with the BMI between 25 and 29. So we don't have to be into that obesity category before we start seeing increase in the risk of these complications and the sequelae of those complications. And unfortunately, we also can see that these are associated with a dramatic increase in the lifetime risks of cardiovascular morbidity and mortality with obesity. Furthermore, we also know that as we increase our weight, we can see that as we go from normal weight to overweight to obesity, that it's really a composite of increased cardiovascular risk is seen. We also see an increase, not to the same magnitude, but an increase in the risk for cerebrovascular disease. And we also see a dramatic increase in the risk of heart failure with preserved ejection fraction. Now, it is in fact visceral adipose tissue deposition and waist circumference, something that a lot of us don't measure routinely, but waist circumference is the best predictor of cardiovascular risk. And we need to take that into account if you're measuring BMI and waist circumference. Different ethnic backgrounds are associated with greater risk at a lower waist circumference. We know from bariatric surgery follow-up and other studies that clinically meaningful weight loss can improve cardiovascular and other outcomes. So in the Look Ahead study, this was a study that looked in over 5,145 persons who were obese with type 2 diabetes mellitus, and it looked at dietary and lifestyle changes. And you'll see this nice, really linear relationship. The greater weight we lose, the greater reduction in CV risk factors, blood pressure, triglycerides, and we see an improvement in HDL and a reduction in LDL. And this is the Dark King population study in China with 577 individuals who with pre-diabetes and who are overweight and obese. And we can see that over time, the control group compared to active lifestyle intervention, so exercise and changes in diet, that there was a dramatic reduction in cardiovascular mortality. Now, I would like to point out it took a number of years for this to develop. We did not start to see those meaningful changes before about 8 years, but the curves continue to diverge in favor of weight loss with a mortality endpoint there. We also know from bariatric surgery that we do see a reduction in various types of cancer and cancer mortality, improvement and remission in type 2 diabetes mellitus and hypertension, a reduced risk of major adverse cardiovascular events in people with cardiovascular disease and obesity, a reduction in stroke, and a significantly lower risk of major adverse liver outcomes and MACE in persons with metabolic associated steatohepatitis and obesity. More recently, we've had the SELECT trial report. This trial randomized over 17,000 patients who had a BMI greater than 27 and established cardiovascular disease to dietary and lifestyle modification and placebo, or dietary and lifestyle modification, plus the GLP-1 receptor agonist semaglutide. I do want to point out that this was not in persons with type 2 diabetes mellitus. That was actually an exclusion. Over the 48-month study, there was a 20% reduction in the primary cardiovascular endpoint in favor of 2.4 milligrams of semaglutide, which was a highly statistically significant p-value less than 0.001. There are other endpoint trials coming soon, and you'll hear about the SURMOUNT trial with another agent, tirzepatide, coming shortly.
When did you start putting on weight?
I first started having weight problems after I quit smoking. That was about 12 years ago now.
Well, congratulations for quitting. It's one of the best things you could have done for your health.
Thank you. Back then, I still lifted weights at the gym and played football with my boys. It wasn't until I hurt my knee around 5 years ago that I really noticed a big difference in my weight. That's when I got this belly.
Have you tried anything in the past to lose weight?
Before my heart attack, I cut back on drinking alcohol. I just drank on the weekends, you know. I cut out chips and sweets, and I tried one of those diets where you cut out carbs and just ate mostly meat. I lost quite a few kilograms, but then it was the holidays and I couldn't stick to the diet and I gained it all back. Since my heart attack, I don't really drink at all, and my wife makes healthier dinners, but nothing seems to help. I still lift weights for my upper body at home, but I can't run or anything because of this knee pain. And now I'm so big.
Your experience is really common. It's often easier to lose weight than it is to maintain weight loss over time. As I mentioned, excess weight, especially belly fat, increases your cardiovascular risk, and losing some weight can really reduce your risk. So I would like to go over some options we have to help you lose weight.
All right.
The main ways to manage weight are through diet and exercise, medications, surgery, or a combination of these.
I've tried changing my diet, like I said, and it doesn't help. I guess surgery might be an option. But my friend was telling me about these medicines that really help people lose weight fast. I don't know if I could take anything now with my heart problems, but I would like to try something for a few months if I could just lose all this weight.
Now, we've already talked about obesity being a strong independent predictor of cardiovascular disease, both in the presence of risk factors, but also independent of risk factors. Obesity is associated with a reduction in your cardiometabolic fitness. We frequently see low-grade systemic inflammation. This can lead to an increased atherosclerotic plaque load and is associated with arterial hypertension. And all these factors have been associated with visceral fat mass, going again back to the fact why we measure waist circumference. And this is important because we believe that these visceral fat mass is a major driver of adipokines and pro-inflammatory cytokines, thus linking obesity with a propensity towards cardiovascular disease there. Also, we know cardiovascular disease risk factors are increased in the presence of obesity. So it's not simply just through the association with obesity and established risk factors. There are independent increases in cardiovascular risk, independent of those traditional risk factors. We see changes in cholesterol metabolism, diabetes metabolism, peripheral changes in the skeletal muscle, and changes in insulin secretion, which can then increase cardiovascular risk, type 2 diabetes, and of course, pre-diabetes. And of course, this is a very complex and multifactorial disease. We know it really involves globally multiple systems throughout the body: the gut, adipose tissue, pancreas, medications, as well as genetic drivers, which then influence both the environment, such as a sedentary lifestyle, psychosocial factors, diet and environment, plus psychological drivers of what we call hedonic input. Maintenance of weight loss is a challenging problem. We know from multiple previous studies that when we go on an active therapy such as dietary changes, we see a reduction in weight. But typically, what we see is when the study is ceased, that in fact weight gain occurs. And in fact, usually what occurs is you really typically go back to the weight that you started at the beginning of the study. Now, these were studies that involved dietary changes. What about when we're using active therapies such as GLP-1 receptor agonists? And it's important to recognize why we regain weight after we've undergone interventions such as a diet. Multiple hormones are in fact released by the adipocytes, which change the way that we seek food. It changes the way we burn calories, changes our hunger, and changes our appetite. So there's a very good biological basis why dietary changes alone typically do not work. Now, if we look at the Step 1 extension study, which randomized persons who were obese to placebo or semaglutide, there was very little weight loss in the placebo arm and very dramatic weight change in those that were randomized to semaglutide. However, once the study was stopped and the off-treatment extension phase occurs, what we saw, just like the dietary studies, was that most folks put the weight back on again, and those impressive benefits were lost. And this data has been replicated not only with semaglutide, but with another very effective weight loss agent, tirzepatide. And this was studied in the SURMOUNT-4 trial, where folks were randomized to tirzepatide, treated for 36 weeks, and after 36 weeks, they were then re-randomized to placebo or ongoing tirzepatide. And similarly to what we saw in the STEP 1 trial, when folks were placed on placebo, they regained most of the weight that was lost, and persons who were randomized to tirzepatide continued to lose weight. Not only was that change in body weight, they also studied waist circumference. And in fact, similar to what we saw with the overall weight gain, when folks were randomized to placebo, they regained that loss of waist circumference again, somewhere around 10 centimeter increase in waist circumference, again suggesting that the weight gain was visceral adipose tissue, which is associated with cardiovascular risk, as we previously discussed. So how do we approach the treatment of obesity? All individuals, regardless of body size or competition, benefit from a healthy, well-balanced eating pattern and regular physical activity. We need to do behavioral modification, and then we step up and we consider pharmacologic therapy, and we may consider bariatric surgery. So we know obesity is a chronic and progressive disease requiring long-term treatment. And I put it to you that this is just like type 2 diabetes mellitus, hypertension, dyslipidemia, and heart failure. Most of these treatments are required lifelong in order to see the reductions in cardiovascular and morbidity. You need to continue the treatment to reap the benefits.
There are some medications that are approved for weight loss that are safe and effective even if you've had a heart attack. These medications can not only help you lose weight, but they can also improve other weight-related health issues like diabetes, blood pressure, and cholesterol. And importantly, they can lower your risk for another heart attack.
That sounds exactly like what I need. How does the medicine work?
The medication is called a GLP-1 receptor agonist. It helps to reset your metabolism. Part of how it does this is by changing the way your belly digests food. It also works in the brain to reduce your appetite. It has a lot of other beneficial effects throughout the body too. And we have specific data now showing that these medications lower cardiovascular risk in people who have obesity.
So how long until it starts working?
You can usually start to see weight loss pretty quickly. But it's very important that we think about your weight as a long-term condition, just like blood pressure or cholesterol or diabetes. The medication isn't a quick fix. You need to think about it as something you take long-term to continue to keep you well. We know from clinical trials that people who stop weight loss medications tend to regain the weight in due course, just like you noticed when you stopped your diet. This means continuing this medication for years, not just months.
All right. What are the side effects?
Most GLP-1 receptor agonists are injectable therapies, so occasionally there can be some mild redness at the site where you inject it.
I have to use a needle.
Well, it's a tiny, tiny needle. A lot of people say they can't even feel it. And you only inject this once a week. After most of my patients try it, they're usually very comfortable. We have one here in the office that I can use to demonstrate how it works.
All right, I guess I can handle that once a week.
Other common adverse effects that people experience when starting out on these medications are what we call gastrointestinal issues, maybe some nausea, maybe some diarrhea or constipation. Occasionally people have some vomiting. For most people these effects are mild, and they're worst when starting treatment. They tend to resolve with time. You might still need to make some changes to your diet, which is the most important thing you can do to help reduce any of these effects. And we can make adjustments to the treatment if you experience any problems at all.
All right.
We will start you on the lowest dose and increase slowly once your body's used to that dose. This will really help avoid nausea. And if you have any worries or problems with the medication at all, you give us a call and we will help you.
Okay, sounds good.
I will let your family doctor know that you're starting this therapy, and they should be able to help you too if you have any questions. And I will also see you back again in about 3 months to see how you're getting on.
What advice do we need to give about starting long-term therapy with agents such as the GLP-1 receptor agonist class? Firstly, it's really important to discuss the adverse effects. GI side effects are common, and this can involve feeling nauseous or vomiting. Some folks develop diarrhea, others constipation. These are expected because of the way GLP-1 receptor agonist works. They're typically transient. They're usually mild in severity, although some folks are unable to tolerate them. And they mainly occur as we start the agents and during the up titration phase. Typically, we start low and go slow. And what I mean by that is you start at a lowest dose, and usually every 4 weeks, we increase the dose. And associated with that, you need to do what we call the 3 E's: educate and explain, escalate to an appropriate dose, and effectively manage the GI side effects. So in terms of education and explanation, you need to reassure patients that adverse events are typically transient. And this is really important advice here. You need to reduce meal size. Importantly, you want to tell patients to be careful because these agents do delay gastric emptying. So very high fat or spicy foods will sit in the tummy and make you feel nauseous and can cause those side effects. So they need to reduce the size of the meal. And we also need to avoid eating when not hungry. As I mentioned before, we need to escalate to the appropriate dose slowly. Typically, we start off, and each 4 weeks, we increase the dose of the agent. Sometimes we need to stop at a certain dose or reduce the dose back if the GI side effects become quite problematic to the patient. And in some folks, an antiemetic or proton pump inhibitor may be the appropriate therapy. Now, importantly, cholelithiasis is seen with the GLP-1 receptor agonist class. Now, other important contraindications in pregnancy and breastfeeding, you do need to consider contraception in women of childbearing age. If you've previously had severe GI diseases, gastroparesis, or inflammatory bowel conditions, because of the effect on gastric emptying, that may be something you want to treat very cautiously. We do avoid in patients with a history of pancreatitis and with a very rare type of thyroid cancer. I would just like to thank everyone for participating in this activity. We've gone through why obesity is important and potential ways with which we can reduce cardiovascular risk and reduce weight in our patients. I'd now like you to please continue on and answer the questions that follow and complete the evaluation. Thank you very much for your time.